Thank you very much indeed. It's a pleasure to discuss these things with you. And I'd like to thank Massimo for allowing us to have these interesting discussions. So indeed, we are all very concerned about appropriate oxygen delivery to the organs. We would like the oxygen delivery to be sufficient so that oxygen consumption can be adequate. It means optimized. It should correspond to the oxygen requirements of the tissues. Calculating these values may not be very helpful because we don't know what to do with the number. So we like to look at indices representing the balance between the three. To my students, I compare the oxygen delivery to the amount of money they can receive at the beginning of the month, if you have a monthly income. Then you spend money for your house and car and clothes and everything. And we hope that your oxygen, money demand is satisfied. If the oxygen delivery is somewhat inadequate to meet the oxygen consumption, SVO2 will go down. And there are people who extract more money from the bank account, they may not be so unhappy. So SVO2 could go down, and it doesn't mean that we need to do something about it. As I said at other sessions, there are people walking in Vienna with a low SVO2. We don't need to jump on them and put them on dobutamine or whatever. No. However, if the lactate levels are increased, that means that there is an imbalance between the oxygen demand and the oxygen consumption. These are people who are in the streets, homeless. Hopefully, we should do something for them. So a high lactate level, unless some exceptions, but the high lactate levels is really a very severe alarm signal. So I'd like to return to this basic equation of oxygen delivery. We all know it's cardiac output, it's the arterial oxygen content, but I'd like to emphasize that the hemoglobin level can basically only go down. We are not interested in polycythemia, are we? SaO2 can only go down, it cannot go above 100%. However, cardiac output can go up or down. So if we think about it, a low cardiac output is always associated with a low oxygen delivery, always. Oxygen saturation cannot go up, hemoglobin concentration cannot go up very much. However, if cardiac output is increased, it does not guarantee an adequate DO2 if indeed the hemoglobin level is very low and or the oxygen saturation. So we need to put these elements together. And I'm concerned about the fact that very often people interpret cardiac output in a very simplistic way. Cardiac output is high, everything is fine. Cardiac output is low, No, cardiac output, as our chairman likes to emphasize, is a little bit like the speed of your car. You want it to be relatively high on the freeway, but in the center of Vienna, you don't want it to go too fast. Same thing, when we sleep, when we're anesthetized, we don't need the same cardiac output as when we do some exercise. The oxygen delivery equation can be dissected in 6 components. And at other sessions, we have spoken about fluid administration, when to stop, blood transfusions, and we may go back to that at this symposium. Maybe we should add a little bit of dobutamine. But I'd like to focus, of course, as it is my topic, on correction of hypoxemia. Now, I'd like to make a very important statement about the words we use. Like you, I often hear people confusing hypoxemia and hypoxia. And I think it's really fundamental to understand the pathophysiologic mechanisms to dissociate the two words. A PaO2 of 45 millimeters of mercury, that's in the blood. It's hypoxemia, like glycemia, natremia, uremia. It's in the blood. Alkalemia. Don't say that a high pH, that's alkalosis. No. To my students, I say, no, not alkalosis. Alkalemia. So I will look for an alkalosis now. Is it metabolic? Is it respiratory? Is it both? So the point is that hypoxemia may not lead to tissue hypoxia. In many cases, especially indeed in healthy individuals having a hypoxic mixture, we would actually tolerate it somewhat because our heart can pump more. Now, if the tissues do not get enough oxygen, that's called a lack of oxygen hypoxia. Hypoxic tissues, lactate levels are increased because there is tissue hypoxia. This is very well illustrated in healthy individuals going to the Mount Everest. At the top of the Mount Everest, of course, they have a very low PO2, 25 millimeters of mercury. Look at the PCO2. Look at the lactate level, 2.2. 2.2 with such a breathing exercise. It means that these healthy individuals can tolerate quite severe hypoxemia by increasing their cardiac output. They have hypoxemia, they have hardly any hypoxia. So, now if we focus on this, it's actually interesting to see that oxygen administration is only 100 years old. Haldane, in 1917, just 100 years ago, proposed to administer some oxygen to hypoxemic patients. And you know, in 1924, less than 100 years ago, it was proposed to put some oxygen in the IV fluids to bring some oxygen easily to the organs. That was Kuttner's suggestion. And indeed, as Luciano Gattinoni indicated, then we became very interested in high FiO2s and the toxicity for the lung. Now we need to separate two things, FiO2 and PaO2. Because a patient with severe ARDS may have a very high FiO2 and yet a PaO2 of only 50 or less millimeters of mercury. And a healthy individual who is on a FiO2 of 0.3 may have a PaO2 of 150, right? 5 times the FiO2. So I would like to focus on PaO2. PaO2 at high levels could induce microvascular disorders. We showed that in healthy volunteers, it's quite dramatic. It alters the microcirculation as assessed in the sublingual circulation. We have done some experimental studies, but our time is very, very limited here. I will jump to clinical data. Well, I would like to start by indicating that hypoxemia, of course, can be dangerous. And I will not show many data. Again, we do not have the time. I will only show one study, which is quite interesting, on long-term outcomes of patients with ARDS. You know, that's from the study from the NIH where they looked at more fluids or less fluids. In the subgroup analysis, they could look at cognitive outcomes sometime later. And it appears that patients who were a little bit more hypoxemic, with a somewhat lower PaO2 than the others, had actually probably more cognitive disorders, as if the brain had been, you know, a little bit troubled by the inadequate oxygen delivery. So we start to see a J curve, which was already proposed by de Jong a number of years ago, showing that hypoxemia can be bad, but hyperoxia, we don't need to speak about hyperoxemia, because hyperoxemia and hyperoxia here are basically the same. When you have high PaO2 in the blood, you also have high PaO2 nearby the cells. I will actually then go a bit faster, but I wanted to say that low PaO2 levels, of course, can threaten the oxygen delivery to the tissues, but high PaO2 levels actually could do the same. And there have been a number of papers on this, including for the brain, including following cardiac arrest, as we reviewed the topic recently. And this is a quite impressive study, looking at an association between hyperoxia and outcome from cardiac arrest. And you could see that in patients who were receiving too much oxygen with hyperoxia in their blood had a lower mortality than the other patients. And again, you can find a number of review articles on this, but this is a study you probably know because it's a very controversial study from Girardis and collaborators who did a prospective randomized control trial on conservative versus conventional oxygen therapy. Limiting the oxygen administration in one half of the critically ill patients. And they found a significant difference in mortality rates. But that, the number of patients was very small, as you can see. So it was perhaps almost too good to be true. I mean, how could it really influence mortality so much? But, it's a very interesting study. It adds fuel to our discussion. And then came the study from Asfar and collaborators, which is a prospective randomized control trial, looking at actually a high FiO2 versus lower FiO2 in the resuscitation of patients with septic shock. It was a dual goal. They looked at hyperoxia and also hypertonic solutions. But the trial was stopped prematurely for safety reasons because it was clear that there was a difference in mortality rate, as in one group with hyperoxia, there was a 43% mortality rate, whereas in the other group, only a 35% mortality rate. And these are the data. The changes in mortality did not reach statistical significance, but there were other clues to indicate that hyperoxia was associated with harmful consequences in terms of ICU-acquired weakness in particular. You may say, why is that? Well, precisely, if there is excessive vasoconstriction associated with hyperoxia, that could indeed influence the oxygen delivery to the terminal endings of the nerves. So it makes some sense, actually. I think it's a very interesting study. I was invited to write the accompanying editorial. I had a slight criticism about the high FiO2. I would have preferred the authors to look at high saturation versus somewhat lower saturation. But thinking about it, and that's the most important sentence of my talk, in the nature, nobody is ever exposed to hyperoxia. We can be exposed to any abnormality when we are sick. We can be exposed to hypokalemia, hyperkalemia, whatever, but not to hyperoxia. Hyperoxia can be only induced by humans, by giving oxygen. Otherwise, you can become hypoxemic when you go to the top of the Everest, okay, but when you go down in Earth, you won't be very hyperoxic. So, yes, perhaps it's harmful. Now, you may stop me here and say, wait a minute, in patients with myocardial infarction, there was this recent study in the New England Journal of Medicine showing no difference in outcome. Read it. It was just published 1 month ago. But look at the mortality rates, Myocardial infarction is a simple disease. It's just a clot in the coronary artery. But when you compare it to our complex patients, it's something which is quite different. So let me end up by suggesting some practical implications, because that's what we would like to hear at the end. First of all, don't go to an oxygen bar. That does not make sense. I looked this morning and I found that there are some oxygen bars in Vienna. You can buy some oxygen cans. Don't do that. It doesn't make sense. And we could perhaps propose, as I did in the editorial, to keep SpO2 at a lower level than 100%, maybe something in between 92 and 96%. And that could be a way to avoid very high PaO2s. Now, as we will hear, the oxygen reserve index we will hear could be a way to also adjust the amount of oxygen that the patient should receive to be in this optimal range. Don't misunderstand me. Don't speak about permissive hypoxemia. Personally, I am not in favor of permissive hypoxemia. I think having a low PaO2 at 90% or below, that could be bad for the patient and for the cardiovascular system in particular, exactly as at the top of the Mount Everest, but our patients are not as well fitted as the young individuals climbing the mountain. This is an old paper from Pesanti showing that indeed if the PaO2 goes down a little bit, think at what I showed about long-term consequences in ARDS patients. If the PaO2 is a bit low, it increases the work of breathing. So again, I think there is an optimal range, not necessarily permissive hypoxemia, but avoiding hyperoxia. And I think on the regular floor, in the future, we will also adapt these interesting observations and monitor the SpO2 in a better way. We should tell our nurses, don't be happy when the SpO2 is at 100%. It may be better to have an SpO2 below this value. And in the future, we'll have these signals, and perhaps transmission of the signal to a central station that will call when the patient requires too much oxygen to reach that SaO2, or when the SaO2 is maintained too close to 100%, and then we could go to the floor. Or even more, this is not from Massimo, I have no conflict of interest, I don't know where it comes from, but I found it interesting. It's a system where they look at SpO2 and they adjust the amount of oxygen being delivered to the patient on the floor. Isn't it smart to have a closed loop system? When the SpO2 goes above 96, 97%, whatever you decide, if it goes above that value, it will reduce the amount of oxygen being delivered. It's too low, close to 90%, it increases the FiO2 that the patient may receive.
Jan-Lui.
I think on the regular floor, we will have these systems in the future. So in closing, if you like, we have some other review papers on this, which are open access. Whatever you do to increase oxygen delivery, there may be some good things, but at the end, there may be some bad things as well. Too much transfusions is bad. Too much dobutamine is dangerous. Too much fluids is bad. And it's the same now for oxygen. Don't give as much oxygen as possible. We need to monitor what we do. We need to have the right monitoring system, and it can be very simple for SaO2. And in the future, we will integrate the signal with others, especially on the regular floor. We don't need just the SpO2 on the floor. We could combine it with other variables to have a better picture of the abnormalities that the patient may present. Dankeschön. Thank you.